Hello, my name is Pete Marzano, and welcome to the Invasive Virtual Spine Conference. We're pleased you could join us for an interactive discussion on indirect decompression. How does it work, and when can I trust it with Dr. Juan Uribe? Dr. Uribe, please take it away.
Thanks, Pete, for this opportunity. So this talk actually is very important because the way that the XLIF works and all the lateral, including actually the A-leaf, is by indirect decompression. So if you don't really understand, and especially when and how to use indirect decompression, you will not have a really happy outcomes in your patients when doing this. So that's what I'm trying to cover today. So the idea is, as you know, I'm Juan Uribe, so I'm a neurosurgeon. I practice in Phoenix at the Barrow's Neurological Institute. We have a very interesting group of spine surgeons there with a lot of variety, but I can tell you that it's amazing. Every time one of our residents, fellow, or even a partner start doing and understanding the indirect decompression, the adoption is huge. Why? Because our life is easier and the patient's outcomes are amazing. You know, it's less, you have less chances of wound infections, CSF leaks, everything that comes related to direct decompressions. So that's, to me, one of the big pluses of the XLIF. However, you have to be careful because it's not for everybody. So in other words, indirect decompression and XLIF, if you are, for example, a golfer, is one more set of clubs in your bag. But this club is actually the best one that you have in your bag. I will say, if you're a golfer, this is the amazing driver. You know, this is not like just one more iron. This is the lead club in your bag. But like everything in life, if you don't use it right, you're gonna be in trouble. So you must be just hitting little irons through the entire course. So hopefully you're a golfer, understand. If you're a golfer, you got it. Okay, let's go to the next one. So what are we going to see today? What I'm gonna talk today? First is we're gonna look at the principles of indirect decompression. I'm gonna show you what is the literature backup on this, because I don't like when a speaker comes and give a lecture and it just come, in my opinion, that's what I think. Actually, I'm going to show you peer review, real facts, how the indirect decompression work. And then, which is very important, is how you select these patients and how it works and where it works. So it's gonna be good. So get ready. It's gonna be on a really good, at least half an hour of indirect decompression and good case illustrations. So this is what happened, yeah? All of us, we're doing all the time this. Big wax, open the patients, they don't want to move out of the bed, managing lumbar drains, just trying to keep up with volume losses, pain, titrate, narcotics, you name it. So obviously, I don't want my life to be like this. I want to show up, do my surgeries, happy patients, go home, amazing outcomes. So how you do that? I can tell you, the less you open the bags and the less laminectomies you do and the less risk of CSF leaks, the better your life. So what are the goals of surgery? Usually when we as spine surgeons, we have basically 4 basic pillars of spine surgery. One is decompress, in this case indirectly, stabilize, fuse, and then obviously the new concept, which is not any more than new, but is preserve or restore the alignment. So you have a surgery that can give you these 4 points, then you have a good procedure. And don't take me wrong, you know, XLIF is a good surgery. Open posterolateral fusions are good surgeries, but the problem is we are comparing to an amazing procedure when it's do it right. which is the XLIF and indirect decompression. And obviously you include the X360, the 5-1 laterals, and you name it. Supine. In other words, is go to anterior column, restore the disc height, and get that nice indirect decompression. Patients absolutely do great. Okay, so how it works. So as you see in this picture is a very simple the way that it works. So you start with a patient that have loss of this height, and then you put a cage, you increase the height, and then immediately you have indirect decompression. And trust me, works amazing. So just by getting and restoring the disc height, and in this case, for example, spondy, moving the vertebra to anatomical correct position, then you have the indirect decompression. So a couple of principles. First, this is actually a really good paper, and it's called the paper from Galidar, but to be honest, there is a couple of them, but which is more important is, this is the big message. When you look at the vertebra, right here and right here, those are the strongest areas of the end plates. So you just put let's say we're doing a T-leaf, you go this way, and you put a little cage in here, you name it, you put it like this or whatever, then this area is very weak on the end plates, they will subside. So when you're doing lateral, you need to take advantage of the epiphyseal ring. Why? Because these cages, as you see here, you want to seat them all the way through and through. That way, you maintain the height that you restore and indirect decompression. In this case, we're using actually a 26 millimeter width cage. You see here how just restoring the disc height, how much you increase the foramen volume and without compromising the lordosis. So, I mean, if you find me a cage that gets much footprint than this one in any surgery of the spine, I would like to see it. Not even an A-leaf, you can go through and through, diaphysis to diaphysis, and on the AP, you're taking basically 90% of that. That's a really good solution. So let's go more details. And you see cases, this is actually what we see most of the time. So you're looking here, cases like this, watch, foraminal stenosis, central stenosis. Then you do the indirect decompression and watch, foramen to foramen, take a look how much it open up. And you're using here the diameter of the central canal. I mean, it's definitely a big change. But then you tend to look that, but I want you to look at this. I'm gonna give you the first pair of predictive factors in indirect decompression. Not only is the disc height, but you're looking here, T2 hyperintensities on the facets. That's a really good predictive factor for indirect decompression. You see here post-op, this space increase all this. So that hyperintensity that was in here actually means this opportunity. Open it up and having a really good indirect decompression. So let's look on some literature. So these are a couple of papers, this is one of the Tony Tomé and the Kepler's and papers, and just to show something on the literature, every time you increase the disc height, your area of the canal increases and you have neural decompression. And here was like, you increase it by 58%, but that's enough to get the symptoms. Which is important is that there is no one on the literature that say how much increase on percentage of the foramen of the central canal is enough to get improvement of the symptoms. And the best example is, a lot of patients, just with a little interspinal device, they do amazing. So what about when we actually see it in the images before and after? So that's why, you know, it's so powerful, the XLIF and the indirect decompression. This is one of the, I would say, the classic paper on indirect decompression. Is a paper from Elowitz on 2011. So it's actually a 10 years old paper now, where they demonstrated that when you perform XLIF and indirect decompression, actually is efficient not only on the foraminal areas, but also in the central canal and on the lateral recess. You know, the question is not for everybody, and that we're gonna see later on. So we keep going. So where is the place and the cage position to have a good indirect neural decompression? And this is another good paper. Using here is 41 patients, 94 levels, and everybody obviously have percutaneous screw fixation. And I want you to pay attention to this, because what is the role of the percutaneous or the pedicle screw fixation, or building a posterior fixation construct? Is that you share the load on the end plates, so it tends to protect a little bit indirect decompression. So that's one of the big reasons to put a posterior supplementary instrumentation. However, you can do it, you know, without that, but obviously that's the role of the screws. So, and then what was interesting is that you have to understand, because there's a lot of speculation on in our field, that they say that you put the cage to anterior, in the middle of posterior, how much is gonna change in the decompression. To be honest, the real estate is so relevant when you go in interbody, especially lateral or anterior, that using the size of cages that we want to use, which is 18, 22 millimeters, or even 26 millimeters width, there is not too much difference. And that's what they demonstrated. There is no significant difference on the amount of indirect decompression respecting to the cage position. So
Dr.
then
we have a question in the chat room, if I could ask real quick. How does intentional or unintentional ALL rupture impact the ability to achieve indirect decompression?
that's a great question, actually, because if you're doing the lateral, and you know, everybody that is doing lateral surgery has what we call unintentional ACR, anterior column release violation of the anterior longitudinal ligament, and how much this will impact on the indirect decompression. So this is the situation, okay? Once you cut the anterior longitudinal ligament, the disc space becomes more free, and is so one of the posterior indirect decompression that you get it, it can be lost by getting increase on the anterior height. So that's how we lost some indirect decompression, by cutting the anterior longitudinal ligament. So my recommendation, if you have an anterior longitudinal ligament, let's say unintended violation, you have to make sure that what you have to be focused is on the posterior disc height, not on the anterior, because then the cages start feeling smaller. So you need to make sure that you increase your lordosis on the cage, you increase your posterior height of the cage, and, which is more important, you need to fixate that cage to one of the vertebrae, 2 or 1, otherwise this cage will migrate anterior. So that's the impact of having an ALL rupture and indirect decompression. Hopefully it's clear, Pete.
Thank you, Dr. Uribe.
Okay, so when you look at the patient selection, which is very important, what patients are candidate for indirect decompression, obviously first you need to make sure that the patient has indication for fusion. You know, you don't want to fuse someone that has no instability, no back pain. So you have to use all your skills. You know, that's why we spent too many years, you know, trying to, you know, residency, fellowship, you name it, and have a really good clinical exam, look at the images, And then obviously have the acknowledgement that is exactly what I'm trying to transmit you today. But there is a couple of questions that you ask the patient that can help when you examine it, when you are sitting with the patient in the room that is good candidate for indirect decompression. And this is probably the golden question, which is this one. Is your leg pain, is this leg pain getting better with sitting or laying down? If they say, listen, Dr. Uribe, if I lay down, my pain disappears. And when I stand up, the pain start right away, or sitting down, it's telling you that it's somehow this axial compression. It means like these spaces, the gravity will make all the structures a little bit more narrow, and then you have the symptoms. So that's a really good cardinal symptom when indirect decompression works. However, you have to be smart. You cannot confuse this one with neurogenic claudication. You know, it's different when you have a patient like an octogenarian having the classic neurogenic claudication, because that patient, what they need is just a laminectomy. Yeah. So those patients don't need a fusion. So I want to make sure that I'm not giving you the message that if you have neurogenic claudication, the procedure is a lumbar fusion, you know, or an indirect decompression. So you have to be careful. This is a symptom that is dynamic. Patients say, I'm doing great when I'm laying down. When I sit down, my pain started, which is different of neurogenic claudication that usually the patient say, I'm doing good sitting or laying down, I stand up, and after few minutes, I start having leg pain. The more I walk, the worse it gets. I just stop, sit down, lean forward, and my pain goes away. That's not a patient for an indirect decompression. That's probably a patient for a laminectomy. And you look at the MRI of that patient, it has a huge, you know, hypertrophies, and so that's not a good candidate for indirect decompression. So that's what, you know, I'm giving you a little more tips on that. Okay, when we look at the images, this is very important. If you become an indirect decompression surgeon on the anterior column, the way that you look at the MRI changes 100%. But if I go and you are an anterior surgeon, your perspective of the MRI is different. If you look at this MRI, if I look at this MRI right away as a lateral anterior column surgery, this is what I look for. First, where is the location of the psoas with relation to the vertebra? Yeah, something that we never look at that. Second, where are the location of the main vascular structures? And third, if there is any vascular or nerve structures on the trajectory of the anterior transpsoas, or you name it, pre-psoas, or truly anterior approaches. Why? Because this is telling me first that I can deliver a safe procedure. And second, right away, once I see that, I start looking for these characteristics. You see this one in here? Remember? Hyperintensity of the facets. And then we look obviously at the CT and the X-rays, looking for loss of this height, anterolesthesis, spondylolesthesis, make sure that we don't have locking facets in here. And that's a sign that we absolutely, we hate it. And this is the way that it looks. When you look at the facets and they look like a mushroom, you know, they look like this, especially on the CT, we're gonna see it later on. These facets are locked right here, you know, they're locked and they don't give you indirect decompression. And that is not the case in here.
Dr. Uribe, another question from the chat room, if I could. Question is, how does bone quality influence your decision to perform XLIF?
Obviously, probably a number one factor for indirect decompression is the loss of this height. But I would say right away with that, obviously, is bone quality. I mean, I don't, and it's in general for any kind of fusion procedure. And my own practice is I don't bring any patient for a fusion without having a good idea what is the bone quality. So if you are in a market, I would say that you can have the luxury, which I have, that having bone density on every patient that I'm going to fuse. When you look at the bone density at the femoral heads, if it's worse than minus 2.5, I will not even consider surgery on those patients. Yeah. If you cannot have bone density on your patients, you can use actually it's a good paper by Dave Polly a few years back. It's called the opportunistic bone density. When you look at the CT and you look at the region of interest and the Huntsville units at the L1 vertebra, and you can have your recommendation for that, you know. And but to me, it's super important. And again, you know, I apologize. I should mention before, you don't want to fuse anyone who has osteoporosis, because you're not only going to have subsidence, but also it's going to be a big problem, you know, hardware failure, you name it. So you have to have, so let's recap a little bit. Loss of this height, anterolisthesis ideally, good bone quality, hyperintensity on the facets. If you have it, that's not mandatory. But the more of these factors, the more of these boxes you check, the more chances to have a really good indirect decompression, yeah? Because what you don't want is, you know, and I see a lot of surgeons on there that they come to me, Juan, listen, I just don't feel, you know, comfortable with direct decompression. It takes me 20 minutes, 30 minutes, and just go and with the tube do a laminectomy or something. But to be honest is, if you don't have to do that, why are you putting the patient through 35 more minutes of surgery? I mean, risk of, as again, CSF leak infections when you don't have to. So that's what makes you good at this. What about if you actually learn when the indirect decompression works, and then you don't have to go through that on every case? You know, your life can become miserable. You can spend, you put hours, how long it takes you to do a direct decompression in addition to the XLIF, let's say, in a year. I don't know how many hours or your life you spend in doing this, that you can spend it with your family, with your friends, doing more research, you name it. This is your time at your disposal. So we keep going. So again, watch this. And this is actually a new manuscript that we put together. It took us years to really trying to get data to do this and get some statistics. It's gonna get published on the Journal of Neurosurgery Spine. Is coming very soon. I mean, we're talking about, it will be hot depressed in a few months. And it's very good because it's basically the whole talk that I'm giving you today in a scientific, statistically demonstrated way. So I'm gonna tell you what it is. And then that's what we did. We're trying to find, which is very hard, is every patient is consecutive. Every patient has a pre-op and post-op CT. Every patient has a pre-op and post-op MRI. So we don't just go like, my patients do good, you know, while you listen a lot. We actually, and we were able to put heavy statistics on it. And I can tell you, you know how hard it is to find statistical significance in what we do. But we find a few factors that are actually big deal for indirect decompression, yeah? So then we found out that, you know, definitely loss of this height is one of the big ones, you know? Spondylolisthesis is the next one, yeah? And then obviously good bone quality. That are very good predictive factors, you know? So, and every time you have that, this is what? This is an example of that images. You see it on the left in this MRI. This one has loss of this height. This is like a spondy grade 1. Best case ever for indirect decompression. Take a look at the post-op CTs. It's amazing, yeah? Without doing nothing posteriorly. Watch, and sometimes you tend to look at this CT pre-op, oh, you know, a spinal process, the space between them is too close, and this is not gonna happen. Trust me, as long as you have these factors, and you see this one, this is also money for us. You see these little guys in here? Vacuum phenomenon. That's telling you that that space will work with you and will help you to restore this height. You see, in this case, for example, you know what is the height of this this cage, which is very important also. I want you to take home with you these measures as well. It's not about over distracting. This cage is a 22, 8 millimeter, 15 degrees lordotic, modulus 3D titanium cage. So just with getting 8 millimeter of this height posterior is enough to go from this pre-op image to this pre-op image. So you see, you cannot be greedy, because the problem is I can go and force a 10, 12 cage on there, but what's gonna happen? Too much stress on the end plates with a larger cage. Then this is what you're gonna have. This image is gonna be like this. Subsidence. Gonna look great initially post-op. In 6 weeks, you're gonna have this image exactly like this. Because why? You're gonna lose all this indirect decompression. That you get it very good with 8 millimeters. You get it with 10 millimeters, it's gonna look great for 6 weeks. But the pressure is gonna be so much on these end plates that they're going to fall apart.
Just more of a personal question to you. You know, your training was very traditional, as many are. What was the catalyst for you in pursuing, you know, XLIF, and as a byproduct of that, indirect decompression as an option in your practice?
Yeah, that's another. I like the question, because one of the most difficult parts when you start doing XLIF is, I remember I came to Invasive, I was trained, I did a course. Actually, I remember my proctor was Bill Smith. Then I went to Las Vegas, I saw him doing surgery. You know, you're like, oh, wow, it's like nice. Then I was not good enough. Then I went to Miami and saw Dr. Haid. And then finally I said, okay, I'm ready to do surgery. But every time that I have the patient in the clinic, I was like, well, too much stenosis. I don't think it's gonna work. Because I was a classic T-leaf surgeon, you know. Everything has to be decompressed, everything looks smaller. This is what I did that actually worked very good in my favor, and I recommend it to my fellows, and they see it in my residents, is when you have the patient on the clinic, you have the images. And you know, at that time, we didn't even have what I'm showing you today, these predictive factors. But you see a patient that can be candidate for a mini open T-leaf, you know, back pain, leg pain. You tell the patient, I have this surgery, which is simpler than your T-leaf. It will put a bigger cage, we'll restore this, it will be a really good ride, but I'm not sure if your leg pain is gonna disappear. But you're taking a much smaller procedure. If you're okay and you're with me, let's do the surgery. And if for some reason you still have pain on your legs and the pain doesn't get better, once we have the fusion down the road, you know, 3 months or something, I can go and do a big posterior decompression. And I start doing that. I can tell you, the failures we're gonna see later on this talk of the indirect decompression is, I mean, it's like a 1, 2, 3%. So in other words, is every 100 patients that I talk to, that 1 or 2 end up in the OR. It was great. And that's what I would get convinced myself that actually the indirect decompression worked. I don't know if that one answered your question to the audience.
Yeah, thank you, Dr. Uribe.
Okay, so what's this, for example? This is important, you know, this is actually, it's not also, you know, everything that we're talking in here is not a hard rules. Don't forget, always is an exception of the rules. But in general, this is what you want, you know? So you want, ideally like this one on the top is ideal, but let me tell you, this patient, you don't see it too much. It's like a healthy people, you know? So usually this is the type of facet that you see. You see here, grade 3. This is the one that we see most of the time, you know? It's on degeneration. These people have been trying multiple conservative treatments, nothing gets better. But then when you do the MRIs, ideally you want to look at this, you know? However, it's not like you have to have hyperintensity to have indirect decompression. Sometimes you don't have it and it works. But what you don't want is the mushroom locked facets, you know. See, this one in here looks beautiful. You see this? Nothing get closer to a mushroom than this. Yeah. So you don't want to have these ones, but then you have to be careful because sometimes you have this and you have pars defect and loss of this height, and still indirect decompression can work. So the summary here is look at the facets, take a look at this anatomical configuration, but then you have to put it together. It's a package. There is vacuum phenomenon, is there a pars defect, there is a spondylolisthesis, and then you make it work. So watching here, for example, another good example, yeah? So this patient has loss of this height. He has a spondylolisthesis, but he has a really bad, it's almost like a fused facet, you know, you don't see it good on this side by looking here. So this patient has, using here, this patient has 2 level lateral, didn't reduce a lot. So, and then you're looking here, the cage, take a look what the cage is. In this case, the cage, you know, it's just like a little oblique. Wanted to know if they make this oblique placement. And this is the problem. When you go oblique, surgeons are afraid to put the cage right here because here is waiting for you, the nerve at the exit of the foramen. But then the problem is if you don't put this cage from one diaphysis to the other diaphysis, if you don't put the cage from here to here, you're facing subsidence, you see here, subsidence. And then you're gonna lose this height, you're gonna lose reduction. And then also, when you have patients with a spondylolisthesis, your main goal is not only to restore this height, but also move this vertebra back. And we have, you know, right now, all the percutaneous systems, you know, especially Reline, the towers of Reline can reduce everything, you know, and now even better with fenestrated pedicle screws, you put your cement and you can pull them up. So we have the technology to reduce, I will say, in my own hands, I will say I'm able to reduce at least 90+% of the spondies. Everybody goes out of the OR with almost reduction, which is different. When I was trained, I remember that I used to say, you know, I was trained with open surgeons. I remember, you know, they used to say, well, you don't have to reduce the spondy. You just make a good posterior decompression. You do a Gill's laminectomy. I remember that Gill's laminectomy, which, you know, you just basically taking the roof of your kitchen to put the refrigerator on. You know, you're moving everything around, and it was a barbarian surgery. So obviously, you don't need to reduce it because there is nothing else, there is no bone around. But then the challenge was, what is the fusion rate of these people? And usually used to be a posterolateral fusions that, as we know, 60–70% fusion rate. And this is, you know, that's a different way to do it, which I don't think, I mean, with the technology that we have today, is nothing that can beat the XLIF percutaneous reduction and indirect decompression. And then the other thing is, this is what we talked before. Again, one more reinforcement. These are the anatomic considerations that you have to have. Ideally, every patient that go to the OR, I would like to have an X-rays. I would like to have a CT and MRI. That's the ideal case scenario, and bone density. With that thing, I can really make a good plan. But then don't forget, if you are an XLIF surgeon, when you put your eyes in here, right away, where are my psoas? Do I have a transitional psoas or not? Where is the lumbar plexus? Not to anterior. And where are the big red, big blue? You know, make sure that I can have good access, no problems, everything good. And then look at the facet configuration. And then finally, I look at the canal. Take a look how things change when you become a lateral surgeon. The last thing that you look is the first thing that you look when you're open surgeon. Open surgeon that look like oh, what is the size of the laminas? How the foramen and this, how the lateral recess, because this is what comes out on open surgery. Here, we just need to find out that we restore everything.
Dr. Uribe, I did just get a question, apologies. Kind of along these lines is, we have a couple of folks that are newer to XLIF. If you had to summarize kind of your ideal first patients or first few patients, what might that look like for our less experienced surgeons on the call as they begin their XLIF practice?
Okay, thank you. Yeah, the ideal patient, I would say, for a XLIF indirect decompression is patients with good bone density, grade 1 spondylolisthesis, and at any level. You know, I wouldn't just wait for a L3, L4, L4, L5. That's the ideal patient for indirect decompression. Okay, so now that to keep going is very important. This is a, you don't want to have this, yeah, subsidence. Say, so you had to prevent subsidence at any cost. How you prevent it? First, make sure that you do your homework. So the patient you have to know what the bone density is, what is the bone quality. Second, you don't want to oversize. Watch this case. You're looking here. I can tell you this case is probably an 18 millimeter width, 10 or 12 millimeter height peak cage. And I'm sure that this level pre-op, it will be similar to this one or to this one. So watch, so you're in here, this height is probably, I don't know, 6, 8 millimeters, 6, 4 millimeters. And this level probably was similar to this one. It's 2, 3, 4 millimeters height. So you're trying to force a 10 cage on it. This is what happened to you. You get very good, but then after 6 weeks subsides, you lose all your indirect decompression. You lose everything, So you don't want to have this kind of cases. So again, you have to make sure that you prevent the iatrogenic subsidence. And the way that you prevent it is knowledgement, The more you know, the better you do it. So again, don't oversize, put the widest implant that you can put, and make sure that you have a good idea what is the bone quality. Take a look at this patient. Even with pedicle screws, it subsides. So what is telling me? This is not the patient. This is not the system. So we as a surgeon, we like to blame on the system. We like to blame on the patients. It's actually, you have to be responsible and accountable for whatever happened to the patient, Let's say, let's evaluate the 3 factors. Okay, if the bone was not good enough, whose fault is it? The patient, or is you, or is the company, or is the instrumentation? Is the surgeon? You shouldn't offer the patient to them. You can send the patient to optimize to a rheumatologist who knows many things to do that. Okay, second factor. If you start with this height that is 4, 6 millimeter, why you really want to restore 200% the height when any level has a similar height? So you have to be also, and this is interesting, we wrote this paper, we put this paper together 3, 4 years ago, which is, to me, is very interesting because the patient hasn't have, the paper hasn't had too much impact. When you look at the Google, Google impact on research, which we were trying to find out what is the normal this height on adults population. And we get a lot of people, trauma patients that never have any back pain, any problems, and we look at these heights, hundreds of CTs. And this is the long story short is, for a 60-year-old person, the normal this height on the lumbar spine is not more than 8 millimeters. So why you want to put an 8, 10, or 12 millimeter cage when you don't have to? So you have to understand that, Unfortunately, the data that we have in our minds is that this height of teenagers, young people, yeah, it's 10, 12 millimeters. But adults never is 12, 14 millimeters. So you have to use that. Okay, so that's the other factor that it was not controlled on this case. And the third one is obviously you have to be very careful on the carpentry. You don't want to be very aggressive with the end plates, because if you roughen it too much, the end plates, you also can have subsidence. And this is something also very interesting. Everybody knows Dr. Lenke. It has been so much impact, he has making too much impact in what we do through the years. And he has a really good paper when he was able to show that it actually makes sense. So when you look at this space and the segment of a patient, the inferior end plate is stronger than the superior end plate. Why? Probably because it has to hold more load. The inferior end plate is holding more load. So when you look at subsidence, general, this is what we think. If the subsidence is on the inferior end plate, probably I will say is a surgeon's fault. Why? Because the inferior end plate is super strong, yeah? Is the subsidence only on the superior end plate? I got it. You know, it's a soft, weaker end plate. So you have to understand that. So subsidence also, you have to be very careful with the carpentry. So you have to be enough to get the disc out of the end plate, but not like when you do in a T-leaf that you want to make holes on there, and because then you're creating the down payment for your subsidence. Okay, so, and this is just a problem, just to keep finishing the talk is, and this is another question that comes out. This is another patient that is coming, this is another paper that is actually coming published. It's gonna be, I just learned that it's gonna be, it's accepted and it's gonna be published on the Spine. Remember, the other one is on the Journal of Neurosurgery, Spine. This is gonna be on the Spine, the Journal of Spine. And this one is very interesting. What we did on this research is we look at all our data, or again, consecutive patients, pre and post MRI, pre and post CT, perfect follow-up, everybody coming to the office for follow-ups, find out when the indirect decompression failed. Remember that when your question, Pete, when you said how you tell the patients do it or not. So this is basically the answer to that. You tell the patients, we're gonna do indirect decompression and we'll see how it works. So what we found is that 123 patients with lateral surgery, 220 levels, one single surgeon, which is good because we're controlling the variability of the surgeons, 74 right side, 45 left side, which it doesn't change in here too much the results. But we find out is that 5 patients out of 127 end up having a direct decompression later on. So 4% is the number. But which is interesting is that out of that 5 patients that failed in direct decompression, actually, after doing the direct decompression and doing a laminectomy, so that not all of 5 got better. Actually, 45% of them, they never got better. So which is interesting is some patients that no matter with direct or indirect decompression, they will never gonna feel better, which is sometimes we don't understand on the spine. So you fix these numbers, probably in my experience, the way that I choose the patient for indirect decompression, the failure is around, the net result is around 2%, which is very low. So I mean, like every time I have 100 patients, only 2, they may end up having direct decompression, which is, I mean, it's amazing, yeah? So if you, because if you just put it this other way, this paper, 123 patients with open direct decompression. What about what's gonna happen with the wound infection, CSF leaks? There is a unique complication that we rarely see on lateral access. You know, infections is almost not existing. Don't forget, lateral approach, the infection rate is very similar, like close to the ACDF. These surgeries by nature don't like to get infected as compared when we do posterior surgeries. And CSF leak is not happening, you know? So that's a very interesting paper that is kind of rounding the entire area.
I do have one question, kind of procedurally related, before we get into some case studies. You know, for a younger surgeon, newer to XLIF, you know, we covered a little bit of this earlier, but there's probably some more to be said. What advice can you share with a less experienced surgeon to help avoid complications, whether it be something we talked about before or neural related?
Yeah, so, you know, obviously, I always compare the XLIF to the, I mean, I'd say the more frequent procedure that is on the side, that is mini open T-leaf. The XLIF is like you're driving, basically, we're talking about cars, you're driving an amazing car. The problem is it's very finicky. You know, the lateral surgery is all about controlling all these variables to make it successful. So first, you have to have a really good training, you know. I don't think it's enough just showing up to a corporation, get trained in one day, and then just go and become that. So it's a platform that you have to use. The XLIF, the lateral surgery, is not a retractor on a cage or any type of monitoring. It's more than that, you know. And that's why, for example, all these variants exist, all these, anterior to the psoas, XLIFs, and this and that coming from that. So trans-psoas approach is amazing, the outcomes, if you follow absolutely all the recommendations. I would say best lateral way to do it is the XLIF. Why? Because it had the best monitoring. To first thing that is identify the lumbar plexus. Second, it has the best platform in terms of understanding and management of the plexus once you dissect it. And third is very standardized. By the experience and hundreds of thousands of cases, we were able to know that there is 6 or 7 steps that are critical in this surgery that you have to master, and you have to do it right. And so the answer is perfect training, good understanding of the anatomical aspects of the lateral, the retroperitoneum, the lumbar plexus, and third, perfect carpentry.
Thank you, Dr. Uribe. We can jump into the cases.
Mm-hmm. Okay, so let's see a couple of cases. So, okay, we have this case, everybody has this case. I mean, all of you guys have been in here have this case. Patients with a previous fusion doing great for a couple of years, start having new symptoms. In this case, it's a very interesting case you see here. This is the classic patient with a hyperlordotic long spine. So they have predilection to create a spondylolisthesis, develop an adjacent failure at L3-4. And this is this classic CT on MRI. He has a previous fusion, which looks very good. But then they develop adjacent segment failure, loss of this height, and anterolisthesis. Okay, so based on what we were looking over the last half an hour is, okay, what predictive factors do we have in here for indirect decompression? Okay, number 1, let me just delete this. Okay, we're gonna go one at a time. Number 1, loss of this height. Do we have that? We're gonna start checking boxes, okay? Loss of this height. If you look at this height of the level above, these heights everywhere, definitely is some loss of this height, okay? Number 2, is there any spondylolisthesis? Yes, we have a gray one in here, you see here. Spondylolisthesis, okay, we have to check. Number 3, do we have vacuum phenomenon? We don't, unfortunately, it doesn't mean anything. Okay, then we keep going on the actual views. We should have a hyperintensities. I'm not sure we have it in here because of the presentation. It's not easy to show the images. And then this one makes this patient actually a good candidate for indirect decompression. This is basically a surgery that the patient had, it's a lateral case and then percutaneous, a extension of the fusion. CT looks great, you see here, the gain of height, the reduction of the spondylolisthesis with the end results or having a really good indirect decompression. So this is just showing a little bit, you can do it, the posterior part, you don't need to go and open a big midline incision. You still can go percutaneous, capture the previous instrumentation, and then in this case, there is underlining here, there is this rod in here attached to the screws that protects the construct, as you see here. So it's good. So you go lateral, you put your biggest cage. This is a 26 cage. So you're taking advantage of the entire end plate. You see here diaphysis to diaphysis. And then you protect, in this case, your indirect decompression with a construct with pedicle screws. So that's a really good case. Any question on that, Pete?
No, I think we're good, Dr. Uribe.
Okay. Go another case. Keep moving forward. So this is another classic patient that comes to all of our clinics. Previous laminectomies, previous fusions, then unfortunately the patient developed instability above the laminectomy. pre and post, amazing decompression. Yeah, that's another good application. Okay, spondylolisthesis again. Okay, you asked me what is a good candidate for indirect decompression. This is a perfect patient. L4, L5, grade 1, grade 2, spondylolisthesis, 50% leg pain, 50% back pain, no response to any conservative treatment. Best case scenario to me, I mean, you can have a better one than a lateral surgery with PERC screws. You're looking here at the x-rays, moving on the flexion extension, you see here. This patient is a perfect candidate for indirect decompression. And then look at the check boxes. Loss of this height, spondylolisthesis, and instability on flexion extension. Then you're looking here, before and after, great indirect decompression, showing a little bit of steps of the surgery. You put your retractor, you start dilating, you put your cage, then you get good this height, good correction of the spondylolisthesis, before and after, happy patient, amazing outcome. You're looking here, you're just showing, for example, you're looking here, this coronal cut, I like it a lot because you see here, this is post-op. Take a look compared to this. So this is the power of the indirect decompression. See how much you actually open it up, the space, and this one will open up right away the foramen. So the nerves can get fully decompressed. So this is before and after. In a case that was very challenging because you're looking here, this case is basically like a big herniated disc on the top of the spondy, you know. So you really can walk away with an indirect decompression in here. Take a look in here, just by this height, this was enough to take all the symptoms away of the patient and avoided big posterior exposure and direct decompression. You see here before, side by side, take a look how big was this herniation here. And you see ligament ataxis, how good enough is to open up all these structures. So that's a really good applications, you know, more cases. Scoliosis is always great for indirect decompression. Why? Because restored this height coronally, when the cages go through, gave a really good correction. You're looking here pre-op. And this is this is like, I would say, sophisticated lateral surgery. Why? Because in this case, this patient needs significant lordosis, you know. So the question is, how can you give lordosis in direct decompression at the same time? So using here pre and post is amazing. So in this case, back to your question, Pete, in this case, we did an anterior column release, we did an ACR. So we cut the anterior longitudinal ligament on these two levels. We put using here the hyperlordotic cages, and still we can provide indirect decompression. So, for people that think that indirect decompression, when you have the ligament cut, doesn't work, actually still works as long as you can get some posterior disc height gain. And that's a really good demonstration of that. So then, yes.
Apologize before you wrap up. The question did come in. You've been active lately in sharing some early results around prone XLIF. Could you speak to that to the audience as it relates to initial experience and what you're seeking as you move forward with the procedure, and any advice for the young audience that we have around that procedure?
Yeah, so it's very interesting because the prone lateral, I would say the prone lateral, the XLIF prone, is basically the answer of a couple of factors. One is really good acknowledgement of the lateral surgery. You know, it took 10 years for us to understand the retroperitoneum, the lumbar plexus. And second, taking advantage of that knowledge in optimizing a couple of factors that we know that works in prone, which is the lordosis that we have, basically lordosis comfort-free on the prone, and then also the ability to perform navigated systems, which they like to be in the prone position. You know, as we know, prone position is probably the most stable position that we can put a patient in terms of when you do navigation, not to lose your reference marks. And second, the timing, because this is another example of a single position surgery. As you know, we can do it also the lateral position, but I would say the biggest advantage of prone lateral is the time savings, the preservation of the lordosis, but you have to understand it's not for everybody. It's not, you don't want your first case to be a prone lateral. You want to have some acknowledgement, some in your backpack. You want to already have some lateral cases, have a good experience, because the anatomy is a little more challenging on the prone lateral. The ergonomics are different, but definitely has its role. You know, obviously 5-1 is limited. You're planning to do an XLIF, because I mean, as far as I know, I've never seen someone doing an XLIF in prone. Which I think is, I mean, we see everything in life, but I think it's gonna be, I wanna see it, you know, probably when we start doing zero gravity surgery. But I would say it's a very interesting option. I would say, again, going to the golf, one more club in your bag, you know. So I have, you know, for example, to me, a 3-4, 4-5 grade 1 spondy. It's a great case for a prone lateral. You know, the time savings is great, but don't forget, you have to know there is a different challenge in prone lateral. You know, the retractor behaves different, the anatomical structure behaves different. So you have to understand that it's like a, you know, best example is pediatric medicine or adult medicine. Pediatric medicine, kids are not miniature adults. It's different, you know. So don't forget when you were in med school that when we learned, when they used to tell us, pediatric is not a little adult. It's actually different, come with unique challenges. Prone lateral is not just doing an XLIF or a lateral surgery with a patient in prone. It has a little nuances. And if you're interested, we're more than happy to walk you through it. And that's a, you know, brand new chapter in our armamentarium.
Thanks, Dr. Uribe. Appreciate that.
That's a pleasure. Anything else? So I would say just what are the takeaway from today? First is, I mean, ligamentotaxis and indirect decompression is a great way to provide good outcomes to the patients. Don't forget, it's a combination of different factors. You need to know what is your patient, what symptoms are. Second, what are it has any of the predictive factors for indirect decompression. And third, can work for multiple indications. It's just not for one single case. So spondylolisthesis, loss of disc height, post-laminectomy syndromes, there's a lot of applications for indirect decompression. But at the end, be smart, use it, but don't abuse it. You know, the modern spine surgeon should be able to do open surgeries, MIS surgery, prone, lateral, you name it, you know. My practice is just not lateral XLIFs, you know. I do big surgeries when I have to do it. I do TLIFs when I have to do it, you know. But I can tell you, without the XLIF, my life as a spine surgeon, it will be miserable. I will be too much time in the OR, too much postoperative issues. You know how you feel when you go home and you don't want to think about postoperative hematomas, epidural hematomas, CSF leaks, pulling drains next day. I mean, it's amazing, you know. When I do an XLIF, I go home and I'm like, what's next? So thanks very much. And hopefully you found that this was a good learning experience.
That was fantastic, Dr. Uribe. Thanks so much for the presentation on indirect decompression. Also, thanks to our participants. We hope you found today's conference informative and departed some information to apply to your practice ahead. Best wishes to all, and have a good afternoon. Take care, everybody.
Thank you.
Thank you.